Hello, everybody, and welcome. This is the Modern Medicine Podcast. I am your host, Dr. Dennis Tian, MD, MPH, graduate of Tufts Medical School, graduate of Harvard School of Public Health, and a practicing primary care doctor with Beth Israel Lahey Performance Network. This is the place to be to hear about all the latest in medicine, all the latest in healthcare. Joining me, as always, of the Boston Podcast Network, my friend David Yaz. Producer Dave, how's it going today, my friend?
Not too bad. We might get into it later, but finally celebrating a football win in Foxborough that maybe actually means something. I know that's exciting.
Yeah, and 100%.
Yeah, life is good. Weather is good.
Good stuff.
Let's go.
Well, that's good. We have a terrific episode planned tonight. We have an awesome guest, Dr. Eugenio Martinez, who is a physiatrist. Do you even know what a physiatrist is? You ever heard of that before?
A physiatrist, someone who treats fuzzy creatures. No, I don't know.
That's a good guess. No, he treats diseases of nerves and muscles. And what he really does is a lot of back pain and neck pain.
Oh.
But what Dr. Martinez and I have in common is we both share a appreciation and an interest in mind-body medicine. Mm-hmm. So we're going to talk a lot about mind-body medicine today and how it factors into some of these things, and especially how it relates to back and neck pain and the way that our emotions and our feelings might affect the way that we experience our illness. So that's going to be good.
Big topic. Yeah. My girlfriend constantly complains of back pain, and I think it's legit, but even she acknowledges that it gets worse during stressful moments.
100% it does. And, there's just such a mistreatment of how we handle back and neck pain. We're going to talk about this when Gino gets here, but lots of surgeries that I don't think need to be had. I've been doing this for a long time. I've seen a lot of people have surgeries they don't need. I see a lot of people get MRIs they don't need. I see a lot of people get MRIs and they get a lot of findings and they get told, oh, you have this, you have that, you have a slip disc, you have a herniated disc. And it gets into their head, and it feeds into their self-perception. It feeds into their image of their illness, and that really makes a difference in their pain when the reality is that might not even be what's causing their pain. So we're going to get into all that with Dr. Martinez when he gets here.
Nice.
And we got a great roster of topics. Let's start it up with In the News, as always.
Let's do it.
In the news.
All right. Where to begin? We have a lot of good stuff in the news since we were last recorded, but as you know, we are recording today, Dave, on September 15th. The weather is beautiful right now, but we know that is not sure to last. And right around the corner, when you think October, what do you start to think? You start thinking cold and flu season is like right at our doorstep. And I want to start with this. The 2025-26 respiratory disease season outlook today was released by the CDC. And this is a report they release every year. This year, they're looking at COVID, influenza, and RSV in particular because they're really the three bad actors. And what do you think they're forecasting this year? This is like the Farmer's Almanac of disease.
So like how bad a year it's going to be for flu? I don't know why I'm assuming the news is going to be bad.
Well, that's why we'll be talking about it.
Yeah.
No, they're saying it's actually going to be the same as last year,
okay.
Which actually was last year. We talked about, if you remember at the time, it was a really bad flu season last year, and I think we're looking at that again this year. And COVID and RSV are probably going to have similar burden. There's a lot of controversy now with the COVID-19 vaccine. This has just become an absolute disaster. So I think people are really confused about whether they should get vaccinated for COVID or not. And to that, I would say, talk to your doctor about that. But I know I'll be recommending to my patients, certainly anyone with high risk should get it. Anyone over 65, anyone with chronic medical problems, respiratory, heart and lung stuff, certainly pregnant women, children under 2. I think that's the way to go. If you're a healthy adult, you've already been vaccinated and you've had COVID, and you don't want to get the vaccine, I think that's probably okay. If you want to get the vaccine and you understand the small risks and benefits, frankly, then I think that's okay too. But for those high-risk people, I really think they should, doctors are likely to advise to them to get it.
Every year, high risk every year, no matter what the last time. Who
knows what's going to change with the evidence? But right now, that seems to be, the safest way to recommend it. I think that I mean, COVID is a lot different now than it was 5 years ago. I think the healthy people that have had it and developed immunity, it's a lot less dangerous. Clearly, we saw that last year. It was kind of less of a thing. You know, it was less deadly than the flu last winter. So I think that, you know, but it's still deadly. It's still deadly to the right people, and it's no joke. COVID was not a hoax. It was not a
No,
it was not a
I got it.
creation
I know
of
it
the
was.
liberal media. It was very real.
Did you get COVID?
I got it. I've got it a few times.
Really?
Oh yeah, I've gotten it multiple times.
I take it that it's higher prevalence among doctors just because you're around it? Or?
Yeah, but I didn't get it in my office. I got it in Disney World.
Well, there you go.
And I actually, this is a terrific story. I got it in Disney World, and it was my last day of my trip. And this was in Omicron, like 2021. We went down there. Maybe we shouldn't have gone. We made it through a 9-day trip without a problem. I felt the slightest little scratch in my throat the day before we left. I said, I better do a COVID test just to be safe. I didn't even feel that sick. Sure enough, it come back positive. So I told Disney, I said, look, I might have to leave. I'm going to need a place to stay. So what do? They put me into, we were staying at the Animal Kingdom. They put us into, what's the campsite one? Fort
Wilderness?
Yeah. In like COVID jail. So I had to go to Disney COVID jail. All my passes were revoked. I couldn't leave the place. They brought me food. I had to order food on the phone. It was a disaster. And actually, after a day, I ended up just leaving and driving home because I wasn't even sick. But yeah, that's my first COVID story.
Rough.
Yeah. But it's coming again. You know, I mean, it's definitely coming again.
Yeah, it's such a different experience now that we actually know a lot more about it than we did the first time, because it was such a mystery the first time, and people were genuinely scared when they got it. You know, by the time I got it, I think I was just annoyed, and it was painful, but it wasn't the end of the world.
Well, I was glad I got it after I got vaccinated. I'll tell you that, because that's the game changer statistically. You know, if you look at the outcomes data, if you've been vaccinated, COVID is really not dangerous
mild.
to you.
Okay.
I mean, it might not be mild, but it's, your odds of having a bad outcome are pretty small. And I was fortunate. I had gotten vaccinated in January of 21. And it was in January 22 that I first got it. So I had the benefit of having gotten vaccinated and boosted at that point, which is probably one of the reasons why I had a mild course. But that's all coming. So these are things people need to think about now that we're getting close to October. If you're a high-risk person with heart disease, lung disease, diabetes, have these conversations with your doctor. And there is definitely still real risk from all this stuff. I mean, flu vaccination is another one. We still recommend universal flu vaccination for everyone now. So that's an important thing to think about. You want to get all this done now and make a plan, be ready, because remember, it takes a few weeks for these vaccines to work. So don't wait till January and then it's the season's half over.
Right.
All right, let's move on to the next thing in the news. Next one up. I got to follow up on this one, not to harp on the vaccine thing, but did you see the story that came out of Los Angeles County this week about the child that died from complications caused from measles infection?
I didn't see that. Tell me.
CBS News, a Los Angeles County child has died due to complications from a measles infection, according to the LA County Department of Public Health. They say the school-age child acquired measles in infancy, and this is what's scary. And then several years later, they developed a rare but known complication of measles called subacute sclerosing panencephalitis. It is an inflammation of the brain that can occur years after infection. This child was a baby when they got measles. They had not been vaccinated because they were not old enough to be vaccinated, picked it up somewhere, and then very unfortunately, a few years later, developed this rare complication and unfortunately died.
Terrible.
It's a terrible thing.
Yeah, and obviously it's the type of thing that we're talking about now because the vaccinations are in the news again, RFK Jr., etc. In the past, you wouldn't even dream, still really wouldn't even dream of your kid being in danger of contracting measles.
100%.
Yeah.
And what they say is that this rare encephalitis, it happens in about somewhere between 1 in 1,000 to 1 in 10,000 cases. But if you're unvaccinated and an infant, it's actually about 1 in 600. So for these super high vulnerable people, we have to remember vaccines against things like measles and polio and it's not just about us. It really is about protecting some of the most vulnerable members of our population. For
sure. Yeah. And that's why we don't get political on the show, but the people that say, oh, this is my choice. If you're going to live in a society, you don't get to do whatever you want. You don't get to drive without getting a driver's license.
Right.
So, you don't get to go to school without proper vaccinations because you're putting people in danger. Same kind of thing.
100%. And I find it so amazing because, look, I'll be completely honest. Like, I get the controversy around the COVID vaccine. I really do at this point. I mean, I still think, let's not minimize what COVID was. And I still think the vaccine is a good idea for a lot of people. I do not understand now how things like MMR, measles, mumps, rubella, and polio and tetanus shots now are becoming controversial. These are canon of medicine. They have a proven track record of safetiness and effectiveness. And all of a sudden now, this is controversial?
Strange. Very strange. It's like moving backwards. There's a reason why we listened to people like Jonas Salk in the past.
Right. We're going to see more of this stuff now, I think, now that this is becoming a thing with the non-vaccination of measles. All right, next story in the news. This is a great story, an interesting story. I think a lot to break down here. Single treatment with lysergide, otherwise known as LSD, in generalized anxiety disorder. Have you heard about this? They want to give people with generalized anxiety disorder LSD.
I've heard of the experiments with hallucinogens in small doses for some people, but it's, as far as I know, it's still not legal anywhere. It's still not mainstream.
It's still not legal. It's still not mainstream. This was a phase 2 clinical trial that was published in JAMA, so pretty much about as legit as it gets, right? And it gave doses of LSD to people with generalized anxiety disorder, and then it analyzed them, I think it was about 30 days later, to see how their score had produced on how their score had improved on an anxiety scale called the Hamilton Anxiety Scale. And what they found, this was really interesting, was that at the low doses, which was 25 and 50 micrograms, there was really no improvement or no statistically significant improvement. But at the higher doses, 100 and 200 micrograms, there was improvement. And that sounds interesting, right? But then I actually did a deep dive. I read this paper pretty closely. And I put on my MPH hat and my Harvard MPH hat, and I put on my crimson Harvard hat, and I went into this. And I'm going to tell you something. I'm just going to put this out there. I'm a huge skeptic of this. I think this study is very biased and flawed, not because it was poorly done, but because when you give people LSD at high doses, what is going to happen to them? They're going to what? They're going to have what?
Trips.
Yeah, they're going to have trips.
Yeah.
So you can't blind people whether they were in a placebo group or whether they were in the intervention group. They know, right? You can't say you got placebo and then you're sitting there and I don't feel anything, right?
Yeah.
Versus the dude that's like, back on a submarine, yellow submarine somewhere, right? In a garden of flowers.
Right.
So the people that got it know they got it. And remember, the way that this outcome was assessed, the Hamilton Anxiety Rating Scale, it's all based on self-report. Even though the researchers were blinded, the participants really weren't blinded. And if you look at the improvements versus placebo, by the way, people that were in the placebo group improved significantly with no intervention whatsoever. That's worth mentioning. The people in the intervention group knew they were in the intervention group. That's implicit bias. So when you see a relatively modest benefit and you're talking about giving a hallucinogenic to people with psychiatric illness, and you're talking about they have to be observed by 2 researchers to make sure they're safe. And these people, a lot of them have substance abuse problems. I am so skeptical of all this.
Yeah. So, but the other thing is, for this to be used habitually by people, it would seem is the idea that you have a hallucinogenic trip and then in the week that follows your anxiety is decreased, or because during the trip,
right?
I mean, you can't really function in society, right?
You could melt down. I mean, they had to lock him in a room and observe them with 2 people during the trip. Yeah. So, and the other thing, and that you raised another great point, limitation of this paper, which is like, where's the follow-up? So there was improvement at 4 weeks. What about 6 weeks? Whatever it was. What about 6 months? What about 2 years? What about if you do this 5 times or 10 times or 20 times? There's so many questions that remain unanswered. How long would the benefits even last? Like, I look at this whole thing and I'm like, I hate to say this. This is like another big pharma scam. This is going to be another way to sell people something based on some, like, really, frankly, jerry-rigged studies that I don't think ultimately are really going to long-term benefit people.
Oh, this is a step towards hallucinogens being prescribed, you think?
I mean, I think there needs to be further study. This is a phase 2 study, so there would have to be like a phase 3 study.
But you have to legalize it first, right?
Yeah, well, you could medically
isn't it-
legalize it, just
Okay,
like
right,
you know,
right.
marijuana,
Like marijuana
was
was, yeah, okay.
legalized medically. So I don't know, but there needs to be a lot more studies before. And I would certainly tell anyone that thinks that I have anxiety, let me rip some acid. That is a horrible, horrible, horrible idea based on this one very not poorly done, but still questionable paper.
I completely agree with that. It seems a bridge too far.
It's a bridge too far.
Yeah.
And I will just one other thing too is like this same thing I'm describing where people in the placebo group versus the control group essentially got unblinded from side effects. This happened with SSRIs too, and because people will get nauseous and dizzy when they got on doses, and this is a known phenomenon. It's sort of an implicit bias in some randomized controlled trials. Okay. All right. Next one up. This is another good one. Artificial sweeteners age the brain by over 1.5 year study says. Did you see this on CNN?
No, but I'm in trouble. I've got a sweet and low habit. All right, go ahead.
People who consume the highest levels of artificial sweeteners, equivalent to just one diet soda a day, saw a significant decline in their cognitive performance on tests, a new study found. People who consume the most low or no calorie sweeteners showed a 62% faster cognitive global decline than those who consume the lowest amount. That's the equivalent of 1.6 years of brain aging, said lead study author Claudia Kimi Sumueto, an associate professor of geriatrics at the University in Sao Paulo, Brazil Medical School. Okay, so I don't know. I looked at this, right, and this caught my eye. Because I'm like, wow, I know people that rip this stuff. Like, I mean, do you use a lot of artificial sweetener?
Yeah, I do sweet and low in my coffee. Or
daily?
Yeah.
Is that-
sometimes sugar, but usually sweet and low.
Does that explain some of this stuff I've heard from you? I'm just kidding.
It explains a lot.
Explains a lot. No, but so I actually, again, I put on my MPH hat and I did a look at this paper, and I'm going to tell you, this is a paper published in Neurology, super credible medical journal, but it just hammers home the point that bad studies can be published in really good journals, because when you read this paper, they did not do a very good job of correcting for confounding bias. Who drinks low calorie sweeteners?
A lot of people, but
Specifically, who's going to gravitate away from sugar and towards a 0 calorie bias? People that are heavy.
Oh, sure. Yeah.
People that have medical problems, maybe people that have diabetes, right? So let's not assume that the association observed in the study was causally the result of the artificial sweetener. I'm calling BS on this study. I think that this is not
so you're basically saying people already with some issues.
Yeah,
are
that's
the ones
confounded.
who, yeah.
If you have diabetes, we know diabetes causes cognitive issues. We know diabetes causes dementia, most likely, right? Vascular dementia is one of the most common forms of dementia. So, and we know any diabetics, they have much higher rates of these diseases. I mean, who's ripping sweet and low? It's the people that can't have any sugar.
Yeah.
You know?
Yeah. Although I mean, I just do it just because to watch my weight, I guess, because to not be doing 6 teaspoons of sugar per day.
Right.
But I absolutely see what you're saying. I mean, you might remember, well, it was probably before your time, but when I was a kid, that there was a huge scare over saccharin, and they thought it caused cancer. It turns out they were feeding the laboratory rats like a gallon of saccharin a day or something.
Yeah, right. So like non-sustainable dose.
Yeah, it got debunked. But this one, I guess I'll have to take a look.
Yeah. I mean, even you just hit the nail on the head, though. It's like, I mean, people that are trying to watch their weight are the ones that are eating this. So,
yeah.
I mean, I think that it's a little presumptuous. I think a better study would need to be done to tease out, what's actually causally related here versus what's just, white noise, which we pick up these kind of things all the time. Association doesn't equal causation.
Yeah.
And that's like the pseudo intellectual anthem. Like everyone likes to say that, but that said, there is some truth to it at sometimes,
Yeah. Well, people that are on diets can be cognitively, set back a little bit because they're pissed off because they're on a diet. They don't want to. Nobody wants to be on a diet.
100%. Right. 100%. Yeah. Absolutely. And think of how people with diabetes and obesity have high rates of depression. We know that affects cognitive performance. I mean, so all these many angles. A study for me to believe that artificial sweetener is causally related with cognitive decline, you have to do a study that really cuts through all that and still shows that association is strong, reproducible, persistent, maybe a dose response type relationship. So that
I got to imagine the scientists hired by Coca-Cola are going to rebut this.
Oh yeah.
Because Diet Coke is everywhere.
Totally. This stuff is everywhere. My sister loves artificial sweetener. She puts it on she'll put it on chicken. I'm not even kidding. It's crazy. I'm sorry for outing her like that. I don't think she watches, fortunately. All right. Next one. Good news on GLP-1s and cancer risk. This is my favorite topic, GLP-1s. These are wonder drugs. I just sit in awe and amazement of the benefits these have. And the reason why I'm so intrigued by all this is because, I've been a believer that insulin resistance is one of the worst things that can happen to the human body and affects all these organ systems. Now we have these great drugs that are really effectively treating this problem, and we're seeing all these crazy benefits from mental health to cardiovascular to obesity and now cancer risk. So the key takeaways, this was in the journal called Oncology Hematology, GLP-1 agonist users had a 70% lower cancer risk compared to non-users in a large retrospective study. Reductions achieved statistical significance for endometrial, ovarian cancers, and meningioma. And for reasons unclear, only one cancer was associated with a higher risk in GLP agonist users. That was kidney cancer, and particularly in those under 65. So I don't know. Is it better to lower your risk of 12 kinds of cancer and live with a little higher risk of kidney cancer? Probably.
I think so.
Probably. But I think it's amazing these things lower cancer risk, or may lower cancer risk.
Refer to all our past discussions on the very drug you're talking about.
Right. Yes. Well, last month we talked about how Mounjaro has which is a GLP-1, and probably the best one, has a 39% reduction in all-cause mortality. And you wonder, hey, trying to explain that. Why do people on Mounjaro die 40% less often than people not on Mounjaro if you're diabetic? Well, look at this. This is a potential landing spot for that.
We don't call this the Modern Medicine Podcast for nothing.
Oh, I'm scouring every day, David. Yeah. Scouring every day. And last, I got one more here, which I got two more, but I got to pick one. I'm going to go with this one. This is right up that alley very quickly. Diabetes review, global burden of disease study published recently. And, oh, my God, The Lancet, which is about as, again, credible a journal as you can get, up to 45% of people that have diabetes do not realize that they have diabetes.
Whoa. I didn't see that coming.
Yeah.
So, and then they eventually discover it, I guess, or then we wouldn't know. But
yeah.
In other words, okay. So, how can that be? They just think they're in poor health, or
they don't realize it. They have no symptoms. They
have no symptoms, and
they don't go to a doctor. The doctor doesn't check.
And so, is this? I take it this is dangerous to not know.
Yeah, it's dangerous. I mean, we have great drugs now that, as we just mentioned, that can treat it. Diabetes is associated with all kinds of health outcomes, bad. And, the longer your sugar is high, the more your sugar is high, the more damage it's going to do to your heart, to your arteries, to your eyes, to your kidneys, all the things that get damaged from high blood sugar. I mean, high blood sugar is the most pro-inflammatory thing going. When we talk about inflammation, nothing causes inflammation quite like hyperglycemia and how it scrapes your arteries from the inside out and leads to inflammatory plaque and inflammatory cascade. So for people that are walking around like this and don't know it, they're just being rotted from the inside out. And it's crazy. But it's easy to diagnose. You know how we diagnose diabetes?
Blood test?
We do an RFK shaman rain dance. No, yeah, we do a blood test actually. Yeah, we do a blood dance. It's a very simple blood. It's called a hemoglobin A1C. It should be covered by your insurance. You get a result the next day. If your A1C is higher than 6.5, you have diabetes. If your A1C is higher than 5.7, you have pre-diabetes. So go to your doctors. Talk about this with your doctor. If you're overweight, if you're under exercising, or you just want to know, you should be able to get this covered by insurance.
Yeah, treat them.
Absolutely. All right. Are we ready for our guest?
Sure.
All right.
Let's take a break here, Dennis, and we'll come right back with
Awesome.
the guest segment. Here we go.
All right, so we want to welcome our guest today. We have an awesome guest, Dr. Eugenio Martinez, a physiatrist from the New England Baptist Hospital. Dr. Martinez, Gino, thank you for joining us on the Modern Medicine Podcast today, fresh from a day in the salt mines of clinical medicine. How are you doing, my friend?
Well, I'm recovering from those salt mines, but it's all good. Yeah, I'm doing great. Thanks for asking me. It's a pleasure.
How many patients did you see today? Too many. Too many.
No, it was a reasonable number. I don't see a lot of patients, Dennis. Typically, I know some doctors see 30, 40 patients a day. I see about maybe 10 or 12.
Right. And one thing about you, Gino, is you like to spend time with your patients, which I think is excellent and not that common in today's world, unfortunately.
So I hear. I've been fortunate that I found myself in situations where nobody was putting pressure on me to, see X number of, minimum number of patients per day. So it's good because, yes, I think it's important to spend time and, hear people's stories and spend time educating them. That's what it's all about.
Awesome. So you're a physiatrist, which is a doctor that, to put it simple and colloquial, you do a lot of work with muscles and nerves. And we're going to talk a lot about different things today, back and neck pain, and we're going to get into mind-body medicine because I think that's a huge thing. But before we even start, get into all this stuff, could you just tell people a little bit what physiatrists do and what it is as a specialty and what kind of problems you treat?
Sure. So the name of the specialty is actually physical medicine and rehabilitation.
Yep.
So we're called physiatrists. Basically, we deal with musculoskeletal problems. It can vary, though. Some physiatrists do brain injury, for example. I don't, but I got training in it. I would say that we are specialists in evaluating function and disability, and by the same token, ability, trying to make people more functional. So
what kind of problems do you see in a typical day? Like back pain, neck pain? What are the typical things that are in your sort of clinical wheelhouse?
Yeah, mostly that's it. I see people with back problems, neck problems. Some people have herniated discs. I also, as part of my subspecialization, do nerve tests or EMGs.
Right.
So evaluating people for pinched nerves, carpal tunnel, pinched nerve from the spine, that type of thing.
Great. And like myself, you're also, you own a practice, right? You own your own practice, and then you also work at the New England Baptist.
Actually, I don't.
Okay.
I'm part of a practice. That's the one that is right down the hall from me, right here in Dedham. And no, I'm not an owner. I just pretty much go there as an independent contractor, I would say.
I see. Okay. And you see patients there.
I do.
And you also see patients at the New England Baptist.
Exactly.
All right, well, let's get into one of the reasons I'm so excited to have you in is because I know we sort of share this like-mindedness on mind-body medicine. And we've had a lot of conversations in the hallways at Dedham Health and Athletic Complex about, when we run into each other, about how mind-body medicine is such like a huge part of illness and pain and like what people experience of their illness and how undervalued it is by most clinicians. And tell me a little bit about mind-body medicine, and specifically, I know you recommended a long time to me a book called by a doctor named Dr. John Sarno, which is called The Mind-Body Prescription. It's a great book. I highly recommend it to anyone out there that is struggling with chronic back and neck pain or chronic symptoms of any kind and wants to get some insight into how their illness, it can be real, it is real, but also affected by their perceptions. Tell me a little bit about all that.
Sure. Well, you well know that, back pain is a very common reason why people come to see you as a primary physician. And it's probably like top 3, right? Something like that, reason, top 5. And it's always been a very vexing problem for a lot of doctors because even though we know the stats say that the vast majority of people with acute back pain, meaning back pain that started recently, gets better on its own without necessarily any specific type of intervention, 90% of people are all better within 8 weeks or so are the stats, long-standing. There's that significant minority of people that don't get better, or it takes longer to get better. Now, it might be because they have a problem that's just going to take longer to get better. Sometimes if you have a ruptured disc, that might take several months to heal. And even those heal without the need for surgery most of the time. But those people that end up going through all these treatments, physical therapy, chiropractic, injections, and sometimes even they go through surgery and they don't get better. And so there was a doctor, Dr. John Sarno, who you mentioned, he wrote several books. But back in the 60s, he was a physiatrist.
Yep.
And he just started to see this trend of people not responding, certain people not responding to physical therapy or just tincture of time,
Right.
Natural healing.
Right.
And so he started to also notice, this is back in the 60s and early 70s, that a lot of these people had comorbid conditions, meaning chronic migraine headaches, peptic ulcer disease, anxiety, things like that. So he started to wonder whether there was some stress reaction. And of course, as we're all aware, people thought about these mind-body situations very differently back then. You were just mentioning anxiety, and all sorts of different theories over the time as far as like what is behind anxiety, what causes it. Now people go on medications to treat it. Back then you did, intense psychoanalytic psychotherapy and that type of thing. But he'd see people, all of a sudden he just said to himself, there's something else going on here. So he just made a bold move and said, okay, I'm going to start treating this as a kind of a mental problem as opposed to a physical problem. And so once he started to do that, and he consulted with some of his colleagues, he practiced in New York City, Midtown Manhattan, and he consulted his, psychiatry colleagues and so forth, and he said, am I on the right track here? How does this work? And so he started seeing great success. And this is back in the 70s. He wrote his first book. It was called Mind Over Back Pain, I think in 1982. But Howard Stern had been talking about him on his radio show. He was a patient of his, and it was a miraculous cure. So I got a lot of publicity from that, and became pretty well known as he didn't want to be a celebrity doctor, but he did have that status, I suppose.
Yeah, well, I guess when you write 4 books or 5 books, bestsellers, right?
Yeah, exactly.
So what is it? What is like the core message of his books? I mean, I read the Mind Body Prescription, but what is like the core message of what he would say drives a lot of the chronic pain?
He believes that most chronic pain is not related to a structural problem like a disc or inflammation or some unhealed injury. Rather, what he thought was that it was your body's reaction to internal emotions, repressed emotions, experiences you've had in your life. You could have been, it could happen when you were a kid, it could happen last week, stress that you're involved in now. I thought one of the most interesting things about his theory was that he believed that people with certain personality traits were at risk, were more likely to develop this condition. People who had perfectionistic personalities, demanding of themselves, demanding of others, and also caretaker type people, or goodists, they like to do good doers.
Right.
And, so he basically would just tell the person, listen, it's not a disc problem like that. There's nothing bad going on. Of course, we all realize that when we have pain, it's a certain type of real, noxious or obnoxious even type of experience, but we're all programmed to minimize or avoid pain and maximize function. So that's a little bit what we're up against. If you have back pain for a day or two, it's no big deal. You can't bend over and lift your kid or whatever for a day or two and it goes away, you forgot about it.
Right.
If it persists, then it becomes a lot more of a complicated situation than, I tore my disc or something like that. Right. So he would tell people to gradually try to get back to your normal activities. Don't be afraid to. One of the things I love that he said, your lower spine, lumbar spine, is the most rugged, durable part of your body, of the human body. Obviously there are exceptions if you develop severe osteoporosis or something, but in a normal human being, your center of gravity is right in front of the base of your spine. That's where, a couple 100 pounds per square inch of force just by sitting are exerted. And then when you bend over and lift something, it's more. So bottom line is that he said, go ahead and try to get back to your normal activities. And then he also said, instead of thinking structurally or inflammatorily or injury-wise about when your pain started, think about what's going on in your life, or what was going on right before that, And it's amazing. That happened to me, actually. I had my experience back in the early 90s. And I had my share of injuries at gyms and that type of thing. But I slept on a sofa one night and started to get some pain, recurrent pain. It was from an injury originally several years prior, lifting weights in the gym. That healed. It went away. And then all of a sudden I sleep on a sofa, get up, I'm like, oh, it's a little achy there. Oh my God, I probably overdid it at the gym the day before. So I tried to get back to the gym and everything, but then it didn't get better. It got worse. So I said, okay, well, it needs time to heal. So I took them out from the gym, backed off from the weights. And there was a progression of avoidance that resulted in no improvement and rather worsening over time.
Right.
So then I was exposed to Dr. Sarno's work. This is probably in 94. Somebody told me about his book. I happened to read Healing Back Pain. And the guy loaned me his book. He said, hey, you should read this. And it was kind of funny.
Were you a physiatrist at that point, or you were still in training? Yeah.
No, I was out. This is 94, so I graduated in 92. So it was funny because this is a guy that was a big-time power lifter, competitive weightlifter, and in the past. And he told me about his back. He said, he actually was running me through some workout in the gym. And I said, no, I can't do that. You know, my back's really bothering me. He said, really? And he said, what's up? I said, well, you know, I told him. And I said, it's just not really getting better. I've had an MRI and whatnot. And he said, well, did you ever read a book by John Sarno called Healing Back Pain? I said, I've heard of that guy. He's like, no, it's real deal. So he loaned me his book. And so I happened to see him a month later. And he says, hey, did you read that book? How's your back doing? I said, you know, I haven't had time to read it, you know. And he said, no, that's not it. He goes, you just don't believe it.
Right.
You know. I said, I'll be honest with you. I'm a back doctor. You know, I know about this stuff.
Yeah.
And he's like, well, how's that working out for you?
Yeah.
Not good. So I went back, I read the book, you know, like a patient, because I was a patient.
Yeah.
And literally 3 days later, I woke up, pain was gone.
Yeah.
After many months. I was taking Valium to sleep at night. It was ridiculous.
Right.
Ridiculous. And I knew what to do. I mean, I was doing all the stretching, trying to work through it. It just wouldn't let go.
Yeah.
Read it, boom. It was like, heal.
Right.
So then I said to myself, what just happened? And can I apply this? This is what I do for a living.
Right.
And so first I thought, well, maybe I'm just crazy. I don't know. It wasn't real. You know, but I said, no, all pain is real. That's my mantra. All pain is real.
Right.
We don't tend to think about that way. Well, you know, I have real pain. Yours is a little less than real. No, all pain is real.
Right.
If you don't believe that as a doctor, then you're going to be missing the boat on a lot of your patients.
Right.
So you have to believe that. So then I just started to try to figure out where it might apply to patients. I went to work the next day, and all of a sudden I was like, oh, that person maybe.
Right.
I have to say, there was the first person I told about was a woman with something called fibromyalgia.
Yes.
So she had pain throughout her entire body.
Yes.
And she was told to come see me by my wife.
Very
who was
controversial condition, by the way.
Well, not to me.
Yeah.
Not to me, but it's been very controversial for years, you know, and it seemed to affect, you know, women, younger women to middle-aged women.
Yeah.
They go to primarily male doctors. All the tests are normal.
Right.
So you say, okay, honey, you need to go just relax a little bit, or, you know,
Right.
this type of thing. And they didn't get respect, you know, it wasn't validated. But the thing is, and this is what we do so much, I'm sure you've talked about this in other
Right.
podcasts, we tend to medicalize situations.
100%.
You know, we label that person. You know?
100%.
And I know if you talk to people experts about ADHD and all what's going on, you know, that, and also just depression and so forth.
Right.
But anyway, yeah, I just started to apply it, and that woman actually got better. She read my book. She worked in the hospital I worked at. She was a nurse, and she worked in a hospice 20 hours a week, full-time ED. She had 6 kids.
Right.
She had an ex-husband who was not a great guy, not very supportive. She had a boyfriend who was abusing her.
Right.
And I knew all this background because my wife had told me, because she'd tell her stories.
Right.
So I knew that. She comes in, she said, well, I got all this. I said, listen, you need to go to physical therapy first of all. She said, I don't have time. I've got all this. I said, if you don't make time for yourself,
Right.
you know what I mean, that type of thing. And I said, well, in the meantime, you need to think about how to do this, how to get the therapy twice a week, okay? We got this great program. We'll talk about it later probably, the Spine Center. And I said, but here's this book. Read this book.
Right.
And I gave her my book. 3 days later, I'm walking down the halls of the hospital. All of a sudden, I hear, Gino, Dr. Martinez. I look, and it's Ann. This woman's about 6 feet tall, about 180 pounds, stocky.
Right.
She came running towards me and just grabbed me and picked me up. And she got tears in her eyes. I'm going, oh, my God, what's going on?
Right.
And she said, I can't thank you enough. I started reading that book that night. I stayed up to 2 in the morning reading it. And the next day I felt better. I said,
Right.
today I'm pain-free.
Wow.
It just blew my mind.
Right.
Yeah.
It's amazing, and like I think that like core tenet of really Sarno's book, and I would say the whole science of mind-body medicine, and it is a science, is that the symptoms are not fake. Like they are real. Like when you have pain, it's real pain. When you have these symptoms, they're real symptoms caused by real physical things. But what you and I have the benefit of now, because Sarno's book was written like 40-something years ago,
Oh, yeah.
and you know, you had your episode 30-something years ago, right? There's been a ton of science that validates a lot of what he said and what we're talking about. And there is this whole field that is called neuropsychoimmunology, right?
Absolutely.
Which is how your emotions and your hormones and your inflammatory responses all interact, and how every organ system in your body interacts with this sort of complex neural, hormonal, inflammatory cascade. So when you say your back hurts because your muscles hurt, it does. That's not pretend. When you're getting sciatica because those muscles are tight and pressing on things. It's real.
For sure.
But it's just the driving force is a very physical. It's when we say mind-body medicine, people think I think sometimes saying their symptoms are imaginary or it's all in their head or it's not real. And it's not the case at all. And that's not what Sarno says in his book either. Yeah. It's very real. It's very physical, but it's being driven between the physical link between our feelings and our bodies and how our bodies respond. Just like, our ancestors got an advantage because when they were about to be eaten by lions, they made a whole bunch of hormones that changed their bodies, right?
That's right.
We're having that same physiology still to this day, except sometimes it's not a lion that threatens us. It's that bad relationship. It's that bad boss. It's that feeling of depression. It's that feeling of despair. It's the situation you don't want to deal with, but it's the same physiology.
Absolutely. I couldn't agree more. And I tell patients that, hey, listen, it's your body talking to you.
Yeah.
It's telling you that there's something out of balance. You can go from the cellular, molecular level all the way to, mind, body, spirit, concepts that people have been talking about for thousands of years.
Yep.
And by the way, when you talk about the, kind of the mind body, people don't believe it or they're skeptical. I've had people, kind of do this when I start to talk. As soon as I
people
bring
get
it
upset
up,
at you.
And I make a joke about it. Like, I'm going to assume that your body language isn't indicating you're not open to what I'm about to tell you. But people go, oh, no, I'm just, whatever. But back in the day, thousands of years, the Buddhists, they didn't separate mind and body.
Right.
This is a foolish Western development.
Yeah, 100%.
Yeah, for sure.
So I don't know if you know this about me, but I did a lot of training in mind-body medicine. I did a program at the Boston Graduate School of Psychoanalysis a long time ago. And I did a lot with the New England Society of Clinical Hypnosis. Like I did a lot of it. They had all these seminars and programs and annual. I went for years.
Did not know that.
Yeah. So I did a lot of this. And, it's like, it's just like, look, one of the things I've noticed over the years is that, I think when you're a clinician and you have these people that are struggling with these kind of chronic pain issues and sometimes the pain is useful to them in a way. Sometimes it supports an identity. Sometimes it keeps a relationship alive. There's some unconscious purpose to the pain that they don't see that really makes it useful to them to stay in this sort of position where they're kind of, staying in that role, experiencing the pain and all these physiological changes that result from it.
Well, what you're referring to actually has been called secondary gain.
Yes, 100%.
Instead of, secondary gain, people think, it's a guy that hurt his, he slipped on a banana peel at work and now he just wants to stay out of work or whatever, he gets caught.
There's that too.
There's that
some
too.
of
That's
that.
more like some malingering, actually. But secondary gain, the person's getting some, unconscious benefit from having a problem. And now I'm getting attention from my wife or my husband.
Right.
Or now I have to take the trash out. They're going to take it out because my back hurts. I have a bad back.
Right.
So, but bottom line is, it was interesting. You're talking about Sarno. Sarno did not believe in secondary gain, interestingly enough.
Interesting.
So, and this is it. But he did believe that there was a benefit to the pain, and that is specifically that the pain served as a distraction for repressed emotions.
Right. Well, I'd say that's secondary gain.
I'm strictly speaking, no.
Yeah.
But that's what he believed. But yes, same idea that there was some benefit. But the issue, and I tell patients, listen, you don't need that pain. In fact, it's ruining your life. In essence, that's what it's ended up doing because it doesn't actually. Okay, so I put it this way. The stuff that you've stored up in your unconscious mind, and everybody can think about something bad that's happened. Like, nobody's had a perfect life, right?
Right.
But if you think about some of the stuff that happened, you think about one of the most painful episodes in your life.
Right.
You've heard the expression, it's made a grown man cry.
Right.
People suffer greatly from these experiences. So it makes sense that in the psychoanalytical world that, your autonomic nervous system is going to be activated
100%.
And cause a lack of oxygen to your muscles, tendons, whatever it is actually happening physiologically and cause pain. And then you're thinking about that. You're not dealing with the other stuff.
I agree 1,000%. And I would also say that, as a clinician, these sort of resistances, when people come in, and I feel like when I will express these ideas to patients sometimes because I feel like I have a moral obligation to tell people the truth, even if it makes them upset. Like I've been doing this a long time, like you have now, and I've seen it from beginning, middle to end. So I will gently, depending on the personality of the patient, how gentle I will be, broach these topics. And if people push back, and I look at that as almost like an active resistance.
You're touching
to
a nerve.
treatment. Yeah,
You touch a nerve.
and the further someone pushes me away, sometimes I think the more likely it is that it's true in that person, and those are the people that need help the most. But one of the things I've learned over the years, Gino, is we can lead the horse to water, but we can't make it drink, and that's why it becomes tricky for us.
For sure. Well, I mean, I can tell you a funny story about resistance. Probably not too soon after that incredible experience with that woman with fibromyalgia, I saw a woman come in. She had a back problem, and her MRI looked pretty good. It didn't show anything beyond normal age-related wear and tear, breakdown of the spine. And so I said, I recommend you do physical therapy. So she did physical therapy. It didn't work. Nothing works 100% of the time, right?
Right.
But it's got the type of therapy that we recommend, you and I, works like 85% of the time, which is astounding. So she comes back to see me. The therapy didn't work. I said, I said, well, you know what? And she goes, what else you got for me? I said, well, there's a book that I recommend that you read. And I told her the name of the book, the same book that I read. And she was skeptical. She said, and she left, and she said, yeah, and come back in a month and we'll talk about it, She comes back and I walked in the room. I knew it was not good.
Right.
She had this look on her face.
Right.
She had the book in her hand. She's looking at me. And I said, what's going on? And she took the book and threw it at me.
100%.
Whipped it at me.
Yeah.
I'm sitting there in shock going.
Threw the book at you.
Yeah, she threw the book, literally threw the book at me. And I said, I could have bought a CD. That's when the era of CDs back then. CDs were $15 or whatever. Anyway, she walked out. Boom. I was a little bit, talking about fight or flight. I'm like, whoa.
Yeah.
I said, okay, no harm done. She didn't pull a gun on me or anything. So, here's the book. And the next person I saw needed the book, gave it to them, and they were cured by it.
That's awesome.
It's like karma, you know?
Look, it's like, you have to be open to the message. If you're not open, there's no point in it.
That's right.
But I would rather, and this is where it gets tricky, like with things like Press Ganey scores and online reviews and stuff like that, because look, I would rather be a good doctor and tell people what I know is likely happening with them and the truth, and have them walk away from me and go find another doctor and say that Dr. Tian is an ass, that Dr. Martinez is an ass. He said something that was just so ridiculous, and how could it be? And it's like, and I'd rather that than be one of these doctors that's like misleading people, giving people drugs or medications that are just setting them up for problems, feeding into their negative identity, which is a huge part of their illness. When people believe that they are damaged or sick or ill, that is a profoundly influential thing in how they experience their illness. That's true for back pain, a lot of psychiatric problems, a lot of illness. When you go around and you label someone, you have this, you have that. Well, first of all, some people just love it because it feeds into this sort of identity they've created for themselves, which is not always frankly, self-serving. Sometimes it can be self-undermining. So people love it. But I would rather put those boundaries down and make people upset and make patients upset than feed into all this, give them drugs they don't need, give them surgeries they don't need, lead them down a path, put myself, this is where I'm going to get really deep and thick here, put myself in a role of paternal countertransference that is completely invalid and false, right? And which doctors do a lot. Sure. And I inherit a lot of people's patients. A lot of PCPs are closing. Their patients come to me, and I see what other doctors do to them, and the transference, countertransference that patients get from some of these doctors that do this. For sure. And then they bring it to me, and they get disappointed in me when I don't give it to them. Well, hey, I don't mislead you. I'm not going to mislead you, and I'm not going to be something that you want me to be for your own wrong reasons. So I would rather put those boundaries down and have someone throw a book at me or write a bad review about me or give me a bad score on Press Ganey than feed into all that. Right.
I will say that, and I think you would agree, that I think for some of these people, their identity, as you said, becomes wrapped up in their illness or their back problem, whatever. I think part of it, though, is that some of these people go for a long time and don't get validated, or they feel, not respected. Their pain wasn't validated, and therefore, then when somebody says, "Oh, you have fibromyalgia," that label now they wear it proudly, like a badge. Now I know. There was an article that just came out. I just saw it. It was essentially a young woman in England who wrote an article about, what do we do? We don't have personalities anymore. Meaning that before, people thought, "Oh, this is a lovable, forgetful person," or something like that. Yeah. Or they're kind of a little bit wacky, whatever, funny, they're eccentric. But now it's, okay, no, I have OCD, or, I have this or that. Right. I said to my daughter, who's 27, and she knows a lot about, she's a social worker, and And she agreed. Yeah, absolutely. And she's Gen Z, obviously. So
Right.
a lot of her friends, they wear their diagnosis like a badge. of honor,
100%.
It's sad.
And really, there's a lot of money in that, right? Because these big pharma companies have been able to say, and you got guys like us, unfortunately, that have 5, 10, 15 minutes to render a diagnosis, make an assessment, make a plan, give a treatment, right? And so if you can put a label on someone, and then there's a product that you can give them for that label, and it's been shown in some study that was, effective. And it's like, what are we really doing to people? We're reinforcing some of their illness in some ways, and many people, I do think it's damaging. And by the way, many of these medications are safe and effective. So I'm not saying that,
Sure.
but I'm saying like how we speak to people and how we frame and categorize these medications. Like you can tell someone they have ADHD and give them a stimulant, that's fine. Or you can have a frank conversation with them about, look, this is you, this is who you are, and this is a tool in the toolbox that can help you. And there's probably nothing wrong with you, but maybe you're just wired a certain way. And maybe this, I've had those conversations before.
Yeah, absolutely.
And I don't want to reinforce negative ego, negative identity, but I can still treat the person with the exact same treatment, but not do that. And that's really what I try to do, and I think good doctors try to do. I want to ask you a little bit about, just because we're kind of touching on this, narcotics for chronic back and neck pain. And I am, people know I'm a stickler, and I've made a lot of patients upset over the years, but just say no to drugs. I mean, and in this particular case is my policy, but I do see a lot of patients that are getting narcotics still for chronic back and neck pain, and it's just, I think, bad medicine.
I agree. I saw a lady came in today. She's 85 years old, and she's on oxycodone. And I said, what are you taking for medication? She said, oxys. Yeah. And that was always kind of a red flag for us as physicians.
Right.
He said, yeah, I need some oxys.
Right.
That's a street name for oxycodone,
Right.
is oxy. I totally agree. And this did not solve the problem. She'd already had, well, long story short, she had a brain problem. She had a shunt put in her brain like 30 years ago. It started to fail several years ago. And the doctor that was looking at her brain also said, oh, by the way, you have some narrowing of your spinal canal, or some stenosis. As far as she can recall, and her sons were there, adult sons, she wasn't really having any neck pain or anything at that time.
Right.
I'm guessing that they treated the MRI, not the patient,
Right.
and did a fusion, a 3-level fusion.
Right.
Now she starts getting neck pain.
Right.
And,
Not
and
surprising.
by the way, the guy didn't do a good job on her shunt. She had to go to Mass General and get it done right.
Right.
But now she gets to the pain service. They run through their injections. She's on medication. Nothing really works. And here's this miserable woman in my office today.
Right.
And I said, listen, there's another way, and this is the way we do it. I spent an hour with her.
Right.
But and she came out. She looked different to me. She looked more positive.
Yeah, right.
But I told her, I said, listen, I'm going to say it just briefly. These medications do not help this problem.
Right.
And we know, in fact, if you look at the animal models,
Make them worse.
they make them worse. And I told her a couple of anecdotal stories, but I said, listen, the animal models say that you can't fool Mother Nature. If you expose a rat to these medications, you look at their nerve later,
Right.
there's going to be increased receptors for these.
Right.
Okay, and that's got to do with the tolerance and all that
Right.
develops for these medications. I really don't use opioids very often. I find myself using them less and less.
Yeah.
And by the way, I just thought of this now, so I'll just say now we're talking about opioids, but you were talking about antidepressant medications and all these, where
Right.
the treatment benefit is only like maybe 15% more than the placebo group.
Right.
But I used to treat people with them a fair amount of time,
course,
and I spent time with Dr. Sarno back in 2001, observing him for a couple of days. It was a fantastic experience, by the way. And so, I said to him, he said to me, no, I think he asked me, he said, do you prescribe antidepressant medications? And I said, yeah, I do. Not all the
Yeah.
time, but I try to be a minimalist. And he goes, oh, really? I said, yeah. For me, I think for some people, you're trying to reprogram the hardware. You're trying to get the software. Here's the software, but the hardware is not working right.
Right,
Okay.
right.
If it were a computer, you just pull the hardware out, and put a new one there, or whatever. Get it done.
Right.
And I said, I think sometimes like an NSAID, not SNRI, or back then it was just SSRI. Antidepressant medication can kind of reset, the chemicals, the brain chemistry. And he said, And I said, well, you don't? He said, no, never. And I said, why not? He goes, because you're just treating a symptom.
Right.
And at that point, I was like, okay, Dr. Freud. But when I came back from that visit, it definitely made a difference. I just, all of a sudden, months later, I realized I had my script, and I'm like, I haven't prescribed, Zoloft
Right,
or whatever
right.
it was, Paxil,
Right.
much at all,
Right, right.
And I also became uncomfortable because I had a few patients that had trouble. They did well on it. That's like, okay, I'm doing well. I did the therapy, I'm doing mind body. Now I want to come off it. I have a bit of a side effect, my libido or whatever. I gain weight. I want to come off it. And I'm like, also when we get down to a certain level, it's like, I do not feel good. At that point, that made me very nervous.
Yeah. I mean,
So-
I think, I think they have their place. I definitely prescribe
sure.
them for a lot of people. I'm not sure if they really help anyone, and they're a real risk. And everyone, we have that conversation at some point about, risk and benefit. And really, I don't know, is there a subset of people that have like a serotonin responsive part of depression, or,
I think so.
Just like, if you say I have abdominal pain, right? And I cut out your gallbladder. Well, that's great if the problem's your gallbladder, but if the problem's your stomach, I've done nothing for you.
That's right.
And I think it could be similar with this, where there might be some people that there's like a serotonin component to the depression, and it's probably, frankly, a minority of people, but some people might actually benefit. Some of my patients swear by them, and in a lot of patients they really do little to nothing for, and they end up off them in a few months. But we use them, and I think they have their place in what we're talking about, which is the management of chronic pain. And like I said, some people makes a huge difference for. I want to ask about another drug we've talked about on the podcast recently. Before we get into MRIs and surgery, before I let you leave, but. Have you tried Journevax yet, which is a new FDA-approved medicine for pain, acute pain?
I have not. I remember I got calls all that week when it first came out.
Yeah.
And it's you talked about it, so just that people that did not catch your other podcast, you
Yeah.
want to explain a little bit what...
100%. So this is a novel agent that works on nerves and how nerves communicate with each other. It was just approved by the FDA
sodium
in
channels
February.
and
Sodium
whatnot, yeah.
channels, exactly.
Yeah.
And I have to say, in studies, the studies look very promising on it. Like it looks to be extremely safe. There's no abuse potential. There's no high, there's no sedative effect. It doesn't work that way, so there's no abuse potential. And it seems to have really safe and effective, tremendous analgesia. And I'm taking the motorcycle outside as a sign that this is valid. But I don't know if you could hear that. But yeah, but it's a very good medicine, and I've given it to about a dozen people now with good results.
Not for, you talking for acute pain or chronic pain? 'Cause
It's
approved for
only
acute.
FDA approved
Yeah.
for acute pain, but I've kind of, we kind of push a little, we're struggling to deal with pain.
I
So,
agree. We're so hungry for something new on the market.
Right.
I remember back in the day, and probably a little bit before your time, slightly, but back when I got into practice, the NSAIDs were coming out like every year, every cup, 2, 3 a year,
Right.
And I remember I prescribed Vioxx a bunch of times, which is a potent anti-inflammatory.
Right.
And as it turns out, it significantly increased risk of heart attacks.
Right.
So,
Right.
and not to get into the whole, the drug companies kind of knew that, looking at their memos or whatever,
right. But maybe they did.
yeah. But anyway, so that again, I guess.
But NSAIDs are no walk in the park. Is
No,
the point.
none of them are.
Yeah,
none of them are. So
Yeah.
I guess I would say I've become a real minimalist when it comes to pharmacology. And I treat a fair amount of chronic pain.
Yeah.
But I see a good amount of acute pain too. So, I would love to have that be a great addition to our
I look at it as
bag.
a tool in the toolbox, and the biggest obstruction, frankly, is getting it paid for.
Yeah.
Yeah. I mean, if insurance
Expensive.
companies will cover it, I've had some people get it, which is I'm surprised I've been able to get it covered as much as I've been to. I want to talk to you, and this is another real topic of interest and passion for me, and I know for you too. But the dangers of over imaging people. Everybody wants an MRI on their lumbar spine, but you know better than I, and maybe you can talk about this. MRI findings very infrequently correlate with clinical presentation.
That's absolutely correct. We're all born with these normal, pristine spines. I wish I had a model here I'd show you, but basically, you've got the bone, the disc, that's a shock absorber between the bones. You've got the joints in the back. You've got a space, the canal that contains the nerves and everything. Right. This stuff breaks down as you age, okay? And Sarno talked about this in his first book. He knew this. He predicted the epidemic of over-medicalization with MRIs. And, when he was practicing, there were no MRIs.
Right.
Barely, they had CT scans, okay?
Right.
So let's just say there's a lot of education guessing going on. So, advent of MRI, amazing technology, as you know. It's like taking a high-def picture of the inside of the body, the spine in this case. But as good as it is, multiple studies have demonstrated over and over again that we don't see the cause of the pain, but for maybe 10% of people that have back pain.
Right.
And there's other studies that have done, a very nice study published in 2015 that looked at a large group of people, ages 20 through 80 years old, half men, half women, put them in an MRI machine and looked at their lower spine. And they basically documented, the 20-year-olds, 30-year-olds, all the way up, the percentage of the prevalence, in other words, of bulging discs, arthritis, all this stuff.
Right.
And it just goes up like this. It's a linear, it's a K equals 1.
But correct me if I'm wrong, and you probably remember the number better, but something like 30 or 40% of 20-year-olds have some sort of bulging disc.
30% of 20-year-olds have bulging discs and also have herniated discs.
Right.
Without pain we're talking about.
Right.
That's the study that you're referring to.
And so like a lot, this is where I think, just to go back to our previous conversation, where I think it's a very dangerous thing. When we do an MRI on someone, and we, as the doctor, in our white coat and our stethoscope, we bring them in our office and we say to them, you have a bulging disc, that's why you have pain. When I'm not really convinced that that's even scientific in most people. Now, if someone, I think, has objective neurologic findings in the distribution of a nerve root, including pain and other neurologic findings, those are the people that I think there's validity to.
Yeah, that's the 10% of people where the MRI shows you the problem. But as a spine specialist, I pretty much already know that they have a herniated disc when I see them. I order it just to validate it. Every once in a while I'd be surprised. There's a cyst growing off an arthritic joint affecting the nerve. Sometimes it could be a tumor in the nerve, okay?
Right.
The most helpful thing about MRIs, Dennis, is they don't tell us what's going on, they tell us what's not going on.
Right.
Which, let me put it this way, exploratory spine surgery, not really a thing anymore.
Right.
Was when I started in 92. Every
Right.
once in a while, we have to go in and take a look,
Right.
MRIs weren't that good.
Exactly. So, you get these, and you have obviously a very, I would say, evolved, big picture kind of view of this. There are a lot of spinal surgeons out there, and I know this from being a primary care doctor, occupational medicine doctor, director of the Boston Fire Department for 5 years, a ton of back injuries. There are a lot of trigger-happy surgeons out there that just want to operate on discs because, what else can you do? Well,
to be charitable, maybe I'll push back a little bit. I think there's a training bias that when you learn, it's like, and the example I give patients is, if, let's say you create this beautiful work of art, and it's in the Museum of Contemporary Art. It's some weird thing, but it's basically a piece of wood, a block of wood, with a bunch of nails sticking out of it.
Right.
But you're a genius. Everybody thinks you're revered as an artist. And let's say there's a carpenter walking through the museum that day with a hammer in his hand.
Yeah, right.
And he sees that nail sticking out. He's like, well, that shouldn't be that way, because his bias is that should be all the way in. Boom.
Right.
And this guy's like, you ruined my art. So that's the example I give patients that. I think I know a lot of really good surgeons that are extremely conservative, but they're excellent surgeons. And so the bottom line is that, they enjoy being in the operating room. Obviously, that's why they do surgery in part. They want to help people. And I think, but you have to be careful, though. We've seen, everybody sees the news about, doctors are human too.
Right. And I think that just in my experience, and I think this has been validated by studies, that people with just non-specific kind of back pain and these non-specific degenerative findings, the outcomes are really not very good when they go in for surgery.
Correct. Yeah. And in fusion, I came out in 92, and fusion hit its peak in the late 90s, 2000s. We're talking about not fusing a spine for an unstable spine or broken spine.
Right.
We're talking about you have a degenerated disc on an MRI. That's causing your back pain.
Which we just said like 30, 40, 50% of the people have.
right. Back then, it wasn't. The information was there. In the 80s, I forget what his name is, the guy from Emory published, he had CT scans that showed bulging discs were prevalent in people without back pain. Right. So the information's been out there if you look for it. But there was that rush to, for whatever reason, we're going to fuse your spine. Right. And the outcome, we're talking about a 50% success rate for a single level fusion for back pain.
Right.
And when I tell my patients they're thinking about it, I say, listen, 50% success means you feel better enough. It could be all better, but better enough. And had no complications, you consider it a success.
Right.
It doesn't mean that 50% of people are cured.
Right. No.
And 50% feel better or worse, they have a complication. So it's not a great operation. And then you talk to any surgeon, they'll agree with that.
I think at this point, I always advise my patients caution. I really do. Yeah. Like I said, if they have objective neurologic findings, I think those obviously are the people that tend to do best with back surgery.
Absolutely.
Those are the people that need back surgery, but that is a minority. Okay, one more thing I want to ask you about before I let you escape from
have a good time. I'll stay longer if you want.
I'm
more
so
questions.
glad. 100%. That's awesome. Tell us, you have really kind of been a big part of the development of the spine program at Dedham Health and Athletic Complex, which is this sort of physical therapy thing that they're doing over there. Tell us a little bit about that.
So the origins, just to keep it short, were back in the 80s, there's a guy named Tom Mayer who was a orthopedic surgeon down in Dallas, Texas.
Yeah.
So back then, orthopedists did it all. On their surgical schedule that day,
Yeah.
they'd have, spinal fusion, a knee scope, and all that.
Right.
The total joint. It would be knees and hips back then,
Right.
70s. But he saw these people coming in, and they weren't getting better with back pain. They weren't getting better. So he'd operate them, and they'd do horrible.
Yeah.
He said, "What's going on here?" Then he realized that the therapists were babying these
Right.
patients.
Right.
Not the post-op, but the people that didn't need an operation.
Right.
And I guess he realized, and I've come to realize that for whatever reason, maybe because if something bad does happen, which is rare in the spine, it's very catastrophic. The neurosurgeons, they called in the middle of the night. You've
Right.
got caudate equina syndrome, which is an
Right.
emergency that happens very rarely, where you become weak and
Right.
maybe paralyzed.
Neurologic.
Yeah, that's as you said, neurologic, clear indication for surgery. But why has the society become to believe that our spines are fragile?
Right.
But that's what was going on. People were told, don't lift any more than 20
Right,
pounds, you're
right.
going to herniate your disc.
Right.
I tell people, hell, before 1930s, they didn't even know that a herniated disc was a herniated disc. They thought
Right.
it was a benign tumor
Right.
of cartilage.
Right.
So on the rare occasion people get operated on, they say, okay, you've got, this tumor, I removed it. Don't worry, it's not cancer. And then 1930s, they discovered, in part right here in Mass General, that it was basically a herniated disc. So basically it was a tear in the outer layer, the inner part comes out, inflames the nerve. Well, they thought it was compressing it, okay? Then it was off to the races. Let's operate on these things, right? And so essentially it's one of those situations where I think there's that bias. Getting back to Tom Iyer, he basically said, okay, why do we treat athletes this way? We push them. They want to get back in the game. They're highly motivated. And so he started this program down there called Pride. And essentially getting astounding results with a very tough population, including workers' comp, which for multiple reasons can be a more challenging
Yes,
group of patients
100%.
to help. There's a lot of stress in that system, inherent in
Right.
the system. So here in Boston, there's Dr. Jim Rainville, who my mentor, my friend, who actually approached a well-known surgeon at the Baptist and said, listen, I think I can help you with your back pain patients, the ones that don't need operations or ones that had operations that didn't do well. He said, sure, come on board. And he started the Spine Center back in 1991.
That's great.
Yeah, and I came to work here in 92, and I started my own little thing, a branch of the Baptist Spine Center down in North Dartmouth, where I was living at the time. Came to work in 99 at the Baptist.
That's great.
Yeah, and then I came over to the Dedham Health Athletic Complex right on the road here. That was in 2001 or so.
But I think what's different about that program than other kinds of PT, and there's probably a role for all kinds of PT in recovery, and we talked a lot about mind body. We didn't talk a lot about biomechanics.
Mm-hmm.
And I think that, for people that have really, frankly, flawed biomechanics, weakened muscles, weakened core muscles, are generally deconditioned and physically inactive.
Mm-hmm.
That is also putting a lot of tension on those muscles, and that's a big part of chronic back and neck pain too.
Right. I mean, I will say that it's a minority of patients that I expose Dr. Sarno to.
Right.
Number one, I don't need to expose the vast
Right.
majority of them to, because like you said, as soon as I taught them about what is true and what isn't true, and reassure them and say, listen,
Right.
there's nothing bad going on in your spine. You have safe pain.
Right.
That's a huge thing I learned from Dr. Rainville.
Right.
And so and the more experience I got, the more I'd see, degenerated spines, and okay, we can push people in
Right.
that spines look like this. So basically we say it's safe. Go and work on this, because we know, speaking to your
Right.
point, that people that have chronic pain have impairment.
Right.
If you don't use it, you lose it. And
Right.
as I said before, our
Which
bodies
is the worst place to be.
our bodies are inherently programmed to minimize or avoid pain, maximize function. So if you bend over, it hurts. You're not going to bend over. You're not going to lift things.
Right.
And therefore, you have a weak, stiff back.
Right.
And that's what the therapy does. And people call it back boot camp is what it's called now,
Right, and it
commonly.
really
So-
focuses on strengthening
And
the core
and
muscles, and that's
stretching,
different.
yeah,
And stretching, and it's a terrific program. I did
It's
it
all important.
when I had a neck spasm a few years ago that I couldn't shake, and I was impressed. I really was.
It works.
It worked.
you know.
It worked great. It did, I'll tell you one thing. It didn't work in 2 weeks, though. When it takes you 40 years to get some way, sometimes it takes a few months to fix it. It's not going to work overnight, but it
sure.
works. All right. I want to thank you so much. This was a wonderful conversation. I hope
my pleasure.
people find this beneficial, and and just find those books, read about it, open your mind, open your heart a little bit, and maybe it will help. It can't hurt, that's for sure.
Can I say just one thing?
Sure.
The Sarno books are great. it's pretty deep. Psychoanalytically, some people read and go,
Yeah.
There are 2 books I recommend to a lot of folks. One is, believe it or not, Back Pain Remedies for Dummies.
Yeah.
Very well done.
Okay.
Very well done. Written
Okay.
by people that they're like, Baptist West.
Yeah,
They're
yeah.
like out in LA area.
The classic For Dummies yellow book kind of.
Yes, yes.
Okay.
But they originally wrote a book called Win the Battle Against Back Pain. It did so well. It's such a great book. It went out of print because they were
Yeah.
enlisted by the For Dummies publishers. And the other book is called Back Sense by a guy named Siegel, Siegel. Highly recommend those 2 books.
Okay.
And I hate to say this, but it's true, I believe. If you read those 2 books, you will probably know more about the spine than most primary care doctors, except for Dr. Tian. Not Dr. Tian, but
probably that.
Most,
Probably
meaning
me, yeah,
51%
probably.
or something,
Yeah,
But
exactly.
it's tough to
Great.
know everything as a primary care doc, right?
I'm a jack of all trades, master of none. It's sort of
That's a
it's a
few.
lot I wear in this world, Gino. Awesome. Well, all right, man. Thank you so much. We appreciate
My
you
pleasure.
coming in, and you are always welcome back here. We'll do it again sometime. Thank you,
All right,
Gino.
brother.
To
Take
talk to you.
care.
All right, so that was great. That was a great guest. What'd you think, Producer
Fantastic.
Dave?
As usual, learned a lot. Well spoken. Didn't get to talk to him about music. I learned before we started recording he's a guitar player, and he
know
also knows his sports, so we'll have to have him back.
I think 100% we're going to
Yeah.
have to have him back at some point. We barely even scratched the surface. I think we did 40 minutes or something. So
I know.
All right, so we're going to wrap up this episode of the Modern Medicine Podcast with arguably the 2 best segments on the show every week, and that is the non-medicine topic of the month and the Boston Sports Minute. So let's start with that non-medicine topic of the month. Producer Dave.
The doc is off the clock, so it's time for the non-medical topic of the week.
Awesome. Well, here we go. The doc is off the clock. The doc is in the doctor's lounge. The pager is on, and he is hoping it doesn't go off. Let's talk about a few non-medicine things this week, Dave. Number 1, I got to say, I didn't even know this happened last night. But did you know the Emmys were last night? And do you care about the Emmys?
A little. I mean, this is the new golden age of television, but I don't know if it's necessarily the golden age of the Emmys. It's I don't know. It must be a hard chore for the Emmys because it used to be, ABC, NBC, CBS.
Right.
That's when I was growing up. And easy to keep track of what's on when. With the streaming services, it's insane. But a couple of great shows got recognition. That show Adolescence, I don't know if you've seen that.
Literally never heard of it.
Yeah. Oh, it's fantastic.
Is it good?
Yeah, it's
What's
just
it-
on Netflix. It's 4 episodes, I think, and it's one day this young boy is sort of out of the blue accused of murder. He's like 10, and his dad, played by Stephen Graham, the British actor, or is he Irish? It's one of those. And it's extremely well done. The actor, he won an Emmy. The 10-year-old, now he's probably like 12 or something. Amazing. So, and it's really about relationships and how you bring up your kids, and kind of scary that it feels close to home as a parent, So
Yeah,
you would love it.
I'll check into it.
Yeah.
I mean, I really am just desperate for like a new show. And the thing is, there's so much content now. It's like hard to wrap your head around like
Agreed.
where to even spend your time. If you only have so much time to watch TV, like where do you even go? There's Apple TV, there's Hulu, there's Netflix, there's so much stuff right now.
Yeah, it's true. I belong to a Facebook group that you might want to check out then. It's called Binge or Cringe, run by
Okay.
my friend Jamie Joffe, who's
I'm in. Sign me up.
Yeah, I will. I'll send you a little invite because you go there when you're looking for something new. There's always tons of new recommendations, and usually people who know what they're talking about. So.
I did like that, like some of like I'm into more like the geeky kind of stuff. Like I'm a big Star Wars fan, so I like the a lot of the Disney Plus shows. I saw that Andor was absolutely tremendous, by the way. If you have any waning interest at all in Star Wars, if you even just appreciated the original, I mean, from 1977, A New Hope movie, watching Andor is just so great because it just syncs so perfectly with the movie in so
it
many
takes
ways.
place prior to episode 4 is the first one that was released with
Yes.
Luke Skywalker. Andor takes place right before that.
Right before that, leading
Okay.
up to Rogue One. So
Rogue
they already
One,
did the
right.
Rogue One prequel. Andor
Right.
feeds directly into directly into Rogue One, and it really is. It's adult television. It's very well written. It's more like a political drama. There's no Jedi. There's no lightsabers. There's nothing like that. It really is just kind of like political intrigue and drama and espionage. It's really great.
I started that one. Got to finish it.
It's
I'm a
worth it.
fan. I love the Mandalorian. And I feel like there's a couple other Disney series that I've seen, but it's
Yeah, a couple of them have been rubbish too, but a couple of them are really good. I mean, we can do that another time because I could go through we can do a whole podcast on Disney Star Wars.
Yeah.
What about the Penguin? Did you watch the Penguin?
Loved it.
Yeah,
Loved it.
So that the girls, was it Sophie? She won
Yeah.
Best Actress last night.
She did. That's right.
She deserved that. Like that she was amazing. For what was the name of the character she played? I'm trying to remember.
I'll check it out.
In the Penguin, but she was so. She played a terrific role, and what was really crazy about the role she played is, as you know, if you watch the show, they get into the backstory of the Penguin. So at one point in the show, she's playing like the sane, kind, normal version of the character, and then at other points she's playing like the insane, warped, demented, and they really tell the whole story of how that all happened.
Right.
And it was just a really great part of the show.
Yeah, the actress is Kristen Milioti, and it's Sophia's the name of the character.
Sophia.
In the Penguin. Colin Farrell, unrecognizable as the Penguin, right?
Wouldn't have known
so
it was
good.
him.
No.
Wouldn't have known it was him if someone didn't tell me.
Yeah. In fact,
I watched 3 episodes until someone told me that's Colin Farrell. I didn't believe it.
Yeah, I know. It's in fact, in times during the show, I forgot it was him.
Yeah.
You know, it doesn't matter because it's like he's just the character. But I love that a dark. You know, I mean I grew up on some of the Batman stuff. You know, I'm not that old that I saw the old TV show in real time, but you know, the Penguin, Burgess Meredith, right. You know, the ultimate, you know, caricature. And then in the Tim Burton movie, Danny DeVito is the Penguin, and he's kind of caricaturish. So it's like they're not real people. This show shows you how a real person could, you know, become damaged, and this kind of heartbreaking relationship with his mother and the whole thing.
Yes.
And kind of a wannabe gangster that's all on the fringes and gets made fun of. And so I thought it was really well done. I think they're going to do a season 2.
I thought it was really, I thought the same way. I mean, it was very dark at the end. Like at the beginning, it almost had, it was dark the whole time, but it almost had this almost like Sopranos-like kind of little bit of lightheartedness to it. And that gradually waned as the series went on.
Agreed.
And the last couple episodes, especially the last episode, was really super dark. But I think that if you're trying to set up this guy into like how someone becomes a super villain and this evil, sick, like sociopathic, violent maniac, like they did a great job of sort of showing his progression through those stages, so that at the end he's kind of this like, hey, at the beginning he's kind of this like low-level criminal. Yeah, he's crazy, but you know, he's also got kind of a whimsical or personality side to him, but by the end he's just a complete maniac.
Very similar to the Joaquin Phoenix movie Joker. Because that movie, one of my favorites ever, and you know, not a barrel of laughs, that movie.
Nope.
You know, but it shows you how, because you know, every depiction of the Joker, he's got the green and the white and the red on his face. He's all messed up, and a lot of people have done a great job playing him. But in that story, we got to see, how does a person become that evil that he's walking around and laughing as people are suffering?
Right.
Well, they give you the answer in that movie, just like in The Penguin.
Yeah, I love the Joker, and you know, Arthur Fleck, which is the perfect name for him. But I have to say, you know, and this is sort of a confession to make, like, people hated the Joker too. I didn't. And I'm going to tell you the key.
You know what? I didn't see it because I got turned away.
Well, let me give you the key to appreciating that movie. Just fast forward over all the musical scenes. Don't watch the music, and it cuts the length of the movie down by like 45 minutes. It cuts out all the stupid Lady Gaga songs, and I thought it was actually, when you did that, I found it to be not bad at all. I went in with a low bar because people trashed it.
People were trashing it. Yeah,
I really didn't think it was that bad.
All right, I'm gonna check it out.
All right. Very, very quickly, one other thing, we got to talk about this. The Karen baseball, the Philadelphia Phillies thing. Dave, your take on the woman that took the baseball from the kid. This was like a few days ago, and it's amazing how quick people's memories are because this is already fading. But what was your take on this?
Well, I think most of us who've been to baseball games know the unwritten rules. And the unwritten rules are, if the ball is free, it's kind of like the rules are the similar for like a catch in sports. If you catch it and you're holding on to it and you have control of it, then no one can rip it from you. But until that moment, it's every man for himself. I mean, you don't want to go pushing people out of the way. But what the dude did was he ran over to near where she was sitting and reached on the ground. The ball was on the ground. He took it. Fair play. The only thing that's kind of distasteful about the whole thing is people calling for her head, and which I guess doesn't matter because no one knows who she is right now. She's probably in a bunker
to me,
somewhere.
That's the most amazing part about this whole thing is that she was able to protect her identity.
Yeah.
No one knows who this woman is, which is unbelievable in today's world. And like to the point where like they've outed like 3 different women that they said this was her, and none of them were her.
Wrongly.
And these people have all been like harassed for a day
Yes.
and have all to come out and say, it's not me. I'm a Red Sox fan. I live in California.
Right.
It's not me. So it's amazing she was able to protect her identity.
Yep.
I do see things a little bit more from her side than most people do. Like I mean, she obviously didn't cover herself in glory the way she handled herself. The ball was right in front of her. The guy came right in and just yoinks, like from The Simpsons, yoinks, just yanked it right out.
Yep.
I can see why that pissed her off. But obviously, if you're her, once you see the ball went to the kid, come on now, you're 60-something years old or whatever. What do you care? Let the kid have the ball. You don't start arguing.
Yeah, it's I don't know. It was uncool, but also I think everybody needs to take a breath. It's like it's not. This has been said many times, but don't judge people based on 10 seconds of video you saw them at a baseball game. 100%. You know, it's not a referendum on your life.
Well, what people did judge her on was her appearance and the fact that she kind of looked like she fit a certain archetype in our country of like, sort of like what you might call a Karen. And people judge this person based on that. And I don't think that's fair at all.
I agree.
If she was an attractive young woman or if she was a man, I don't think people would have reacted a certain way. But what this thing was interesting for is it hit the nerve of some of the traditional political divisions we have in our country because of the way she looked, and people just went crazy over it.
Yeah, frankly, that's just sad.
It's very sad. All right. Can we wrap this up with the Boston Sports Minute before we go? Because we actually have it's September 15th. Yesterday was a great day for Boston sports. We got something good to talk about for once.
Here we go.
It's the Garden. It's Teddy Ballgame. Yaz and Poppy in Noma. It's Brady and Larry and number 4 Bobby Orr. It's Fenway Park. It's the Boston Sports Minute. Let's go.
All right, let's go. The Patriots yesterday, Sunday in Miami, probably had their best win in a long time. I mean, beating a quarterback they couldn't beat in a stadium they never win in, and they had every excuse to lose that game. These are the kind of the games that they have been losing for the last 5 years. A lot went wrong for them in the second half of that game, and they still managed to win. It's just so antithetical to what they've been the last few years. And I do give Mike Vrabel a lot of the credit for that because I think his personality and the resiliency that he has sort of espoused, and the mental toughness that he has sort of espoused, I thought it really showed yesterday, and that was the difference in the game.
I'm with you. Fun to get a win. It was kind of nail-biting time in the second half, and we wish they didn't have as many penalties. We wish they tackled more. But you're right. That place, Miami, whichever stadium they've been in over the years, has typically been our house of horrors. Even during the Brady years. Even during the Brady struggled to win it and had that one super memorable game early in his career when he hit Troy Brown for that 80-yard bomb to win it.
2003.
2003, right. But it's always, for some reason, always a tough place to play. And Tua was 7-0 against us. We'll take it at this point in the Vrabel journey because it's not supposed to be perfect yet.
Yeah, and I mean, they've just had exactly. They got to get the wins wherever they can get them at this point. I had them 1-1 after these first 2 games when the schedule came out, but I had it backwards. I thought they would beat the Raiders and lose in Miami because it's such a house of horrors down there for them. But they were able to figure it out.
How come we haven't seen who's the slot receiver that just went undrafted?
Efton Chisholm.
Yeah, Chisholm. How come we haven't seen him, you think? Or have we? I
haven't seen him yet, but I think we're gonna. I mean, one guy I'm tired of hearing about, and I think he's a okay little player, but let's stop putting these big expectations on Pop Douglas because he's okay, but he's nothing great. And I think that hey, you're right. Give Chisholm a chance.
Well, the part of a big part of the engine of the Patriots dynasties were either Wes Welker or Julian Edelman or Troy Brown in the slot, and it's just that Brady had that play perfected, and it's like it seemed like any time you needed 8 yards, 12 yards, you could get it, and it seemed like. I don't know, just from watching the YouTube show. No, is it on YouTube? Yeah, the YouTube show Forged in Foxborough. Chisholm seemed like he might be that guy, and Edelman was either undrafted or a very lowly drafted guy, and so I hope we get to see him. But overall. And what'd you think of Drake May?
I thought he had a terrific game.
Yeah.
Best game of his career. I think people were being a little too hard on him after the first game. I mean, he was really good in the first half in that game. And then he threw the pick against the Raiders. He kind of fell apart, and that was concerning. But it was his first game in the system. He's only played 13 or 14 games. Be a little patient with him. I would say at this point, he's been pretty good. I think 6 of the 8 quarters he's played, he's been the best player on the field. So, I'm excited for him.
And no mistakes yesterday. I mean, that's huge.
Yeah.
Because we, the team made enough mistakes for him with all those penalties.
Right. But
yeah, I don't think not. I mean, he took a couple sacks, but that's okay. Right. Sometimes a sack is not the worst thing in the world.
Not the worst.
And I'm bullish on May. Who knows? I'm trying to encourage myself to have fun this season because they're probably going to be around 500, right? And we don't need to make the playoffs this year. We got to take a big step forward.
I'm calling it now. They're going to be Pittsburgh this week.
Great.
I'm calling it now. So
I can't believe the Steelers are favored by a couple points. I think.
Yes, they are
in Foxborough.
That's
a little odd.
They had a strong performance in week 1.
I know.
People are going on that, and I think the Rodgers name. Let's talk very quick before we wrap it up. We got 1 minute left.
Okay.
Boston Red Sox, huge win last night. They were making me nervous with that game. 6-0 lead in the first inning. They have been playing well. They're kind of coasting into the playoffs on fumes, but what can you do? They've been ravaged by injuries, which is kind of the unwritten story of the year. They're hanging in there. I think they're going to make the postseason, and they won a big game last night.
Yeah, it's great. Thank God we didn't get swept by the Yankees because it would have just felt all wrong. And the Yankees have sort of disappointed this year, but there they are. They're still sitting there a couple games ahead of us. Yeah. It does look like we'll still make the postseason. I say we still have a puncher's chance if our top 3 starters are right, because you only need 3 starters in the playoffs, right?
Right.
So, Bayo and Crochet and Giolito, if they're all on, and a few clutch hits, Roman Anthony hurts. Not having him, no doubt.
Let's hope he comes back.
Yeah, he might come back.
I mean, I think that's a huge loss for them. But if he comes back for the postseason, this team was much better when Roman Anthony was out there.
I know.
That they were a much better team.
Yeah.
All right, well, listen, that's all the time we're going to take. I want to thank everyone that listened to this episode of the Modern Medicine Podcast. Have a great, great month, everyone. Keep your eyes open for our content. Find us on Facebook. Find us on Instagram, YouTube channel. Subscribe. And please ask questions. We love to get them. Be safe, be healthy, and be well, everyone. We'll catch you next month.